Are we ready? Is AVH ready?
ADSD.
No, AVH. Are we ready to go?
Oh, they.
Just wanted to make sure. Good morning, everyone. I'd like to call to order the Joint Subcommittee on Human Services, and welcome to everyone in attendance. Happy Raiders Day. Go Seahawks. And if the committee secretary can please call roll.
Assemblywoman Brown-May. Assemblymember Dickman. Assemblymember Hathen. Assemblymember Hibbets. Assemblymember Howdigi.
Here.
Assemblymember Monroe Moreno. Assemblymember Yeager. Senator Canizaro. Senator Dondero Loop. Senator Stone. Senator Titus. Assemblymember Mosca. Chair Nguyen.
Here. Good morning, everyone. I know that it's that time of year. We have a bunch of members presenting bills in other committees this morning. So as those members arrive, please mark them present for today's meeting. And with that, we will just get right into this. Today we have 5 Aging and Disability Services budgets, or the ADSD budgets. And I will ask you to come up to the table and begin when you're ready. I would ask you, I know that we have a couple of budgets that have similar questions. So if you don't have any objection, if you can present those regional center budgets together in addition to the Family Preservation Program kind of as a group, I think that would be helpful for the committee.
Good morning, Dina Schmidt for the record. With me today, I have Jeff Duncan, our agency manager. I have Jessica Adams, our deputy administrator, and Ellen Cresilius, our deputy administrator, who will be helping me with the presentation and mostly with questions. So we'll get started. On page 2, your normal org chart, and we'll just jump right into budget account 3166, which is our family preservation program. This program does provide financial assistance on a monthly basis to families who are caring for individuals with severe and profound intellectual and developmental disabilities. In this program, on slide 4 is the caseload projections. We have a projected growth of about 1% in the upcoming biennium for this budget account. And on the next page, you'll see the decision units for this budget. M200, 201 represent our caseload growth. And thank you for letting me just keep going, because I thought we were going to do some questions. So on to the next one. Developmental services on slide 6. We provide developmental services are operated through 3 regional centers, which are dedicated to supporting individuals with intellectual and developmental disabilities. The programs assist these individuals and their families in achieving their personal goals, living independently as possible, and being active members in their communities. You can see the various services that we provide on this slide. And we also operate a 24-hour facility, an intermediate care facility for individuals with intellectual and developmental disabilities, also known as an ICF. Before we start into these budget accounts, there's 2 points of clarification I would like to provide based on some of the public comment we've been hearing this session. The first point of clarification is that Betty's Village is a housing option. I want to make it clear that it's not related to ADSD services. So an individual may have a lease or rent from Betty's Village, but that doesn't guarantee or tie to ADSD services. So our residential supports are aimed at supporting individuals in the least restrictive setting as possible. So that could be in any apartment complex, housing it like Betty's Village, family homes, shared living with a family, or in a home with multiple people being served. So just want to make that point of clarification. The second point of clarification that I want to make sure we all understand is that regional services are not all waiver services. So developmental services, we serve over 8,711 individuals. Of that, 3,081, or 35% of the people we serve, are on waiver. So there's a large population that are not on waiver. So just that point of clarification as we move forward. Moving on to slide 7. This is just the funding source for developmental services, we are funded through general fund, Medicaid, as well as county reimbursements. And you will see in this this budget, we have a budget decision unit relining our FMAP for the last three, across all three budgets. So going into slide 8, our rural regional center budget. Projected caseload growth here is 3% over the upcoming biennium. And then on to slide 9 are the decision units for rural regional centers. M201 represents our caseload growth. I will say that there's a budget amendment coming for this decision unit and the E250 decision unit. We identified a double counting error. We had put the cost of the rate increase into 2 different decision units inadvertently, and so there is a budget amendment correcting that error. M502, this is a decision unit requesting a standardized assessment to meet new federal requirements, which do require us to do assessments on 90% of the individuals enrolled in the waiver every 12 months. The benefit of this assessment is that we can better predict our future service costs. We can determine service costs that exceed the usual costs, so we can identify when maybe somebody's enrolled in a service level higher than what they actually need to be supported. We can also enhance the accuracy and efficiency of our service delivery. We're really looking forward to this because it creates a non-biased, independent assessment of need, and pulls our case managers who are close to the families out of that process. And so the assessment is done independent of the case management. E250, this is a decision unit to maintain our rate increase from last session. And then E680 is elimination of a part-time position that has been difficult to fill over time. Moving on to budget account 3279, Desert Regional Centers. Caseload growth is projected to be 13% in the upcoming biennium. And on slide 11 is our decision units. Again, same decision units, M201, which is our caseload, M502, the standardized assessment decision unit, and E250, the continued rate increase. And on slide 12 are some additional decision units for Desert Regional Center. We have E805, which is a psychologist part-time position now that we would like to move to full-time in order to provide those assessments, technical assistance to the team doing those standardized assessments. E266 is requesting 5 new developmental support technicians for ICF, or intermediate care facility. Currently, we have 5 DST4s that are supervised 10 homes. So there's 10 homes on our campus, which really means those 5 individuals each have 2 homes and anywhere from 20 to 25 staff that they are required to supervise in a 24-hour setting. So our goal for quality assurance purposes is really to get that to 1 supervisor per home and more of a 1 to 10 to 20 or 10 to 12 supervision ratio. E902 is 2 management analysts and 1 auditor to transferring over to the Nevada Health Authority. Okay, and moving on to Sierra Regional Center on slide 13. Projected caseload growth is 15% in the upcoming biennium. And I will say that the caseload growth, as you can see, these numbers, 15% may not seem high, but for us, that's really, we've never had caseload growth quite like we're seeing right now. So, slide 14 are the decision units, same decision units as the other 3 budgets, caseload growth, standardized assessment, and the continuation of the rate increase. And on slide 15 is a transfer decision unit. This is transferring 2 maintenance repair specialists, 1 custodial worker, and 1 custodial supervisor to the State Public Works Division. We were previously in a building where these staff were supporting the building that we were in, and we've now moved to a building that is maintained by Public Works. And so it made more sense for them to take these positions. And then they could utilize their resources across all of their projects. And with that, that is the end of the regional center budgets. We will be happy to take any questions.
Wonderful, thank you. I'll just give the members a little time to catch up, make sure that they're all on the same page. I appreciate you being able to go through those. I think we have some first questions from Assemblymember Mosca regarding the Family Preservation Program.
Yes, thank you, Chair, and good morning. Thank you for that very helpful overview. I'll go back to the beginning, please. And my question was around how would the approval of the budget amendment to reduce the revenue transferred from the Fund for Healthy Nevada impact the agency's ability to serve families who use this program?
Good morning. Sorry, Jessica Adams, for the record. So it is a reduction in the funding for the services. As of right now, our projections are that we will have enough money for everybody that's on the program as of July. So what happens is we just watch the budget, and as the budget goes along, if we think we're not going to have enough money to pay people, we start a wait list for that service.
I'm sorry, so could you just say that last thing? So do you anticipate a wait list?
Jessica Adams, for the record, I'll have to get back with you on that. I don't remember what the projections were. Again, this is it's growing only by 1%, so we're only adding a couple of people into the program. So I don't remember offhand. I'll have to get back with you on that.
Okay, thank you. And then I just have a last question. Just what factors were considered in determining the decrease of the funding transferred from the Fund for Healthy Nevada? And was there any consideration to replace the transfers with other revenue sources such as general funds?
Ellen Crecilius. When we received information from the director's office that the Fund for Healthy Nevada funds needed to be reduced, they looked, as part of the process, my understanding is that they looked across all the places where the Healthy Nevada funds go and adjusted to minimize the impact on individuals.
Okay, thank you, Chair.
Oh, now that I've got you all in the hot seat, it's me asking some questions. And I appreciate you being able to present those three kind of budgets and budget decisions together. I'm just curious on what the thought process was that went into the decision making in creating this. I can see that in this base budget, you did include the wait lists, and you did fund the wait lists from the previous biennium. So moving into this budget, those are included, but which is a huge departure from what we've ever done before, or we haven't done in over a decade. You didn't include the projected wait lists moving forward. They're not included in that budget. So can you tell me a little bit about that? Was it just to save money? Was it just to cut those costs? I'm just curious on what the thinking was, just because it is such a significant departure from what we have been doing to try to get away from these wait lists.
Dina Schmidt for the record. So a couple of things that have gone into that decision. One is we have been on a enrollment freeze because of the budget pressure for the current fiscal year. So our providers have not been building capacity and hiring new staff. And then with this projected caseload growth, as you've seen, right, our projections are so high, we don't anticipate that our providers will be able to even meet caseload projections, let alone wait list at this time. For them to ramp up the number of staff they would have to hire and the number of folks that we have to get enrolled, we'll be lucky to keep up with our current caseload, let alone getting into that wait list. So that was part of the decision, and you'll see it in the future in the next budget account that we go through, the same idea. It's our staff that we can't hire fast enough to meet the caseload projections. So it's really being realistic about whether we're actually going to be able to serve that population. Do we want to? Of course. But the reality is we're unlikely to actually dip into that wait list number in the next biennium.
I mean, we've always had that problem. We've always had wait lists, and I think as this body, we've always made a conscious decision to do what we can to move forward and to eliminate those wait lists. And this seems like a significant departure from that. And I'm just trying to wrap my head around the idea that we've just thrown up our hands and said, well, there's just going to be incredible wait lists, and we're just going to continue to add on to that in the next biennium. Have you, with respect to these other agencies, I know that I have concerns as we move into some of these other budgets that they are not fully funded in the way they are now. And hearing from people in the community, it sounds like these wait lists, and we've already stopped services for some of these individuals already in the current biennium. So are there any strategic plans moving forward to eliminate those wait lists with the ever increasing caseloads?
Dina Schmidt for the record. So just to clarify, so we have stopped new enrollment in services. We haven't stopped any current services. So anybody currently receiving services and developmental service continues to receive those services. Again, it's the numbers that we're looking at. Our staff have to, or our providers have to staff up, right? They have to find a home to rent for, let's just say, for example, supported living arrangement services. They have to find a home to rent. They have to find staff, hire them, train them, get the home certified through our processes. That all of that takes time. Let's just say that would move in 4 people into a home. So the volume of our caseload growth is unprecedented. We've never seen it before. Yes, we've always asked for wait lists, and we anticipate in the future biennium getting back to that. But right now, because we're kind of starting from behind the 8 ball, it feels like, we have to give our providers the ability to catch up and just hit those caseload projections. And again, I think keep in mind that what we do when we are in this kind of a situation is we do prioritize our wait lists and the individuals coming into services. So we always prioritize based on the highest level of need. So we would serve the people in the greatest need first through this biennium to make sure that there's no risk of institutionalization.
Can I ask just one last question before I allow other members to ask questions? What kind of conversations have you had with the providers to determine that they are unable to accommodate these increased caseloads? Because my conversations are in direct opposition to what you're representing here about how these providers are unable to do this work. They have indicated that they are able to do this work. They are able to provide these services, and the funding has just been cut off, and so they're unable to do it, not because they don't have the manpower or the resources to do it. I'm just curious on what kind of conversations you've had with those providers.
Jessica Adams for the record. You are correct. Our providers are able to hire more people. They have told us that they're able to hire more people. I think that the concern is that just with our caseload growth budgets, our service budgets are already going to be increasing somewhere between 35 to 90%, depending on the regional center. That is a tremendous increase in service dollars, more than we've ever gotten in one biennium. So it's going to still be a tremendous amount of services being given, new services. I think our concern was that going over those already historical levels, that we would end up reverting money, which we don't want to do.
Thank you. I have so many other questions, but I will take those offline and have those conversations with you. Next, if we can go to Assembly Member Monroe Moreno.
Thank you, Chair. My questions are on the division-wide, the developmental services, our regional centers, and specifically, well, I have a few questions, if that's okay. Thank you. You went over a lot, and I'm sorry I came in a little late, so I may have missed it, but could you discuss what factors might be contributing to the projected increase and the supported living arrangements, the caseloads, particularly at the Desert Regional Center, when compared with the actual caseloads from the FY24.
Jessica Adams for the record. Clarification, you're asking for the overall caseload or just the caseloads for SLA programs?
Well, let's do both. Yeah.
Jessica Adams for the record. So overall caseloads, I think that developmental services, we have been doing tremendous outreach. What we have heard for years and years is that nobody knows that we're here. So we've made a lot of changes with that, especially down in the Las Vegas area. We've actually partnered very, very closely with Clark County down there. We go to the Child Haven campus every single week. We do a lot of stuff with juvenile justice. We're going out across the state and visiting schools and going to all sorts of events and letting people know that we are there. So I think we have seen more applications coming in than we've ever seen. Our denial rates are staying about steady, so it's just that we are reaching people who would have qualified for us previously that never knew about us. So we are seeing tremendous caseload growth down at both DRC in the south and up at Sierra Regional Center in the Reno-Sparks area. Rural Regional Center, which had been on actually a decline in caseload the last several years, is finally starting to see again an uptick in the caseload. So I think, again, and it's just us getting out there, letting people know that we are there. As our caseloads increase, people want services. And so we end up with more people on wait lists for all of our services. It is becoming more and more common as well, especially when you're talking about supported living arrangement services for some of those folks. They're walking in our doors homeless. They are walking in our doors where their families or whoever they were living with are no longer able to care for them. And so we have to get them into SLA services as soon as we can.
And then the human resource position, we always want to increase the services that we're able to provide or the benefits to those clients. How would that position, that additional position, help with the benefits that the clients are being provided?
The additional, Jessica Adams for the record, the additional human resources position will help ADSD overall and especially Desert Regional Center. I believe our caseload growth results in about 80 new staff having to be hired over the next biennium. Just for Desert Regional Center, that is the most staff we have ever hired in one biennium due to caseload growth. And we always need more HR people to help with that process.
Last question. Thank you, Madam Chair. So in the budget amendment that we received, the start date for the positions would be changed from October 25 to January 26. What's the anticipated effect on client services in changing that date in the caseload positions, both at Desert and Sierra Regional Centers?
Jessica Adams for the record. Some of those positions, I think, were administrative assistant positions, things along those lines. Those would not really have any direct impact to people served. I do believe some of those positions were our developmental specialists that do act as service coordinators. By delaying 3 months, it's possible that caseloads could go up for the existing service coordinators. I will add, though, that it has historically been very hard for us to hire anybody as of October 1st. It has traditionally not been until about January that we've actually been able to bring new people on.
So just to follow up, so basically the change in the start date just makes it more in line with what the actual practical hiring date could be.
Jessica Adams, that's correct.
Thank you.
Thank you. If we can go next to Speaker Yeager.
Thank you so much, Chair. Thank you for being here this morning. I have a few questions on M502, the Standardized Functional Needs Assessment Budget. And the first question is, could you talk about approximately how many standardized functional needs assessments must be completed annually for recipients of waiver services currently?
Jessica Adams for the record. So right now, there is no current requirement for this type of assessment to be done. This was based on a change to federal regulations that requires us, I believe, by, July 9th of 2027 to have at least 90% of people that are on our current waiver to have this assessment done every single year. Since we obviously have people that get those services that aren't on waiver, and one of the things that we're going to be using for this assessment is to try to standardize the types of services that people need. We will also be doing these assessments on individuals who are receiving SLA or jobs and day training services, but not on the waiver.
And Chair, if I could ask a follow-up on that. So I just want to make sure I understand, for the folks that are on waiver status, you said you're not currently doing these, but the reason you're going to start doing them is because the federal government is requiring it. Is that correct?
Jessica Adams for the record, that is correct.
Okay, great, thank you. And then one last question, if I could, Chair. Could you just talk about how you anticipate the standardized assessments would differ from the existing practice of social assessments for clients, and what the benefits of using the standardized functional needs assessment would be?
Jessica Adams for the record. Currently, the social assessment process is really a conversation that a service coordinator has with that person, with their family, with maybe providers that are already serving them. And it really just kind of goes through various areas of that person's life. What is their health like? What is their current housing? What kind of help do they need for medical needs? It is not a standardized assessment, as in that it is not something that is a uniformly asked questions to every single person, that is based on, in the case of the assessment that we're wanting to use, international data on if you ask these certain questions, then these are the types of services that that person should need. So it's a very different process than what we are currently doing.
You may have answered this, so if you did, I apologize that I didn't hear it. What percentage of the recipients of the waiver services, like, do you have a breakdown for all, if you're going to implement these across the board, what percentage are you mandated to do this by the federal government anyway?
Jessica Adams for the record. So for everybody that is on waiver services, it is 90%. Currently, we have, I think, a little over 3,000 people on that waiver. By the time this has to actually be implemented in 2027, we'll have more. So it's thousands that every single year we would have to do.
So how many people not on waivers, because you're going to do this across the board for people that are not on waiver too, so how many additional people are there total?
Jessica Adams for the record, I believe the current budget was to us to be able to do about 5,000 a year in assessments.
And then can you also talk about, it's my understanding that part of the reason that you want to do this assessment across the board is it'll perhaps give you some more predictability in what those caseload numbers are going forward. Is that correct?
Jessica Adams for the record, not caseload as much as the cost of services.
That's what I meant. I'm sorry, the cost of this. Okay, wonderful. Thank you. I think next we'll go to Assemblymember Howdegui.
Thank you, Madam Chair. My questions are around maintaining the service provider rates. It's Decision Unit E250. I know you touched on it just very quickly in your presentation, saying you were looking to maintain the increased rates from the last legislative session, but it's my understanding that the agency indicated that the rate increase factor for the entire caseload was inadvertently applied in the decision unit for caseload growth. And so just a few questions. One, can you discuss what other factors in addition to the rate increase may be contributing to increased cost, such as shifts in client needs, changes in access to services, or other changes impacting the cost per individual served?
Jessica Adams for the record. Yes, we are seeing, it appears we are seeing a shift in intensity of services that individuals are requiring. So the most expensive services that we have are those 24-hour supported living services. The rate study was anticipating roughly a third of people each would fall into each of 3 tiers of service. As the actual rates have rolled out, we are seeing people trend more towards the tier 2 and the tier 3, the more expensive levels of services, and that is entirely based on the amount of staff that home needs in order to operate. We've also had to implement a custom rate tier, and those are for people who have service needs even above and beyond tier 3. So currently, I believe at Desert Regional Center, it's about 14% SRC. It's about 17% at RRC. Only about 1% of people are in that custom rate tier. For those custom rates, the providers have to justify what it is that they need all of that staffing for, and there's actually a statewide group that they have to bring that to. So we are just seeing, for whatever reason, increases in the amount of staffing that people need.
Okay, can I keep going, Chair? Thank you. And so what are the average wait lists and wait times for individual services currently?
Let's see, Jessica Adams for the record. For our supported living services, at Desert Regional Center, we have 430 people waiting with an average wait time of 361 days. At Rural Regional Center, we have 75 people waiting with an average wait time of 215 days. And at Sierra Regional Center, we have 174 people waiting with an average wait time of 343 days. For our jobs and day training programs at Desert Regional Center, 651 people waiting with a 446-day average wait time. Rural Regional Center, 35 people waiting with a 127-day average wait time. And Sierra Regional Center, 114 people waiting with a 337-day average wait time.
And then one last question, Madam Chair, thank you. And you all know, you've seen our Ways and Means and Finance presentations, and, you know, where there's so much uncertainty with what's happening at a federal level and how that's going to impact our budget. And so for any reason, if the continued increased funding wasn't going to be approved or couldn't be approved, have you guys identified ways to align expenses?
Jessica Adams, for the record, you're asking about the Medicaid funding? Or,
No, just for your, like, if we don't continue the increased rates, what the agency plan to do.
okay. Jessica Adams for the record. If we don't continue the increased rates, there's really only a couple of options that we would have. One, we would potentially be able to go to the Centers for Medicare and Medicaid Services to ask for a rate reduction. That those typically are not approved, but we could try. If CMS says no to that, then the only other option we would have would be to cut people out of current services.
I don't know. I think just hearing those wait times is just appalling. And I know that we have those, but to know that those wait lists were not incorporated going forward, if you have people waiting a year, this is just going to get worse. Do you anticipate not include, like, what those wait times are going to look like moving forward because they were not made a priority in this budget going forward? Do you have any predictions on what those wait times will increase to?
Dina Schmidt for the record. So I would say that those wait times are higher than normal because we have been in an enrollment freeze for services. So they're already higher than we would normally see. So with our caseload decision units, we would anticipate those numbers would start to come down because we would be prioritizing people based on their need, but we would be starting to serve some of those people that are currently waiting, enrolled in regional center but not receiving SLA service, for example. So the average wait time should be coming down over the next biennium just because we're currently not enrolling anybody in SLA, so that we're just building that time. So you will start to see a reduction in the wait list and the wait times.
Well, you'll see a reduction in the wait times for the people that are currently on the wait list, but you'll see an increase in a wait list of people that are wanting to have services, but you're not accepting them. Do you distinguish between people, or do you just not even allow people to apply moving forward? It just seems like we're creating this, what it appears to me and probably other members of this committee, it looks like you were severely underfunded in the last biennium, and we're compounding this moving forward into the next biennium. Do you have those numbers? Obviously, I know you have limitations on what your budget looked like, the direction you got from the executive branch on what you needed to increase in there. But if we've already stopped services in the previous biennium, how long are these monies go? I mean, it seems like they're going to run out like within the first year.
Dina Schmidt for the record. So we always have to work obviously within our budget. We don't anticipate the ask we're asking for here, this E250 and our caseload decision unit together, we anticipate we'll be able to serve all the people on our caseload growth. And that if, I don't have we can follow up with the exact numbers of what the number of individuals that is. It's a large number of people that would be served. So we anticipate this being enough to continue reopen services and serve our caseload growth.
I'll probably reach out and have staff reach out to you to see what it might cost and what it might look like, so we don't get into a further hole when it comes to wait lists and wait times. With that, I'll move to our next, I think we have a question from Assemblymember Brown May.
Thank you, Chair. Thank you. Lovely to see you here this morning. We're going to move to DRC's Intermediate Care Facility. So it's Budget Unit E26, Decision Unit E266. There is a request for additional staffing. Can you talk about how the agency has been managing the workload that you have right now? I understand there's been lots of overtime. So how are you handling the workload currently at the Intermediate Care Facility and the need for additional staffing?
Jessica Adams for the record. So at our Intermediate Care Facility, or ICF, last session, the legislature approved a 2-grade pay increase for all of our developmental support techs. We saw that absolutely worked, and so we have actually had relatively low vacancy rates, which is something that's quite different. I think when we were here last time, we were at about a 25-30% vacancy rate. I believe currently I have 2 open developmental support techs, so that definitely helped. As far as the day-to-day staffing, it is based on the people who are there and the staffing levels that they need at that time, which can change from day to day. We could have somebody who maybe needs a 2 people to 1 staff ratio, and then maybe something happens, they have some sort of health issue, they have something change, and they have to switch to a 1-to-1 staffing. So it is always hard to predict how many people we're going to need on the floor any single day. So yes, overtime is happening to make sure that we are able to staff all of those people served. As far as the developmental support techs 4 that we are asking for, we have, as Dina said, we have 5 developmental support tech 4s acting as supervisors over our 10 ICF homes. They're each taking on 2. That's 20 to 25 staff. That is a lot of staff to supervise. It is a lot of staff. Like, they have been somewhat managing it, but obviously things can fall through the cracks when you're trying to staff or trying to supervise that many people. So it is our hope with adding the 5 more and moving down to that one home, the quality of their supervision will go up. They'll be able to better serve people that are living in those homes. And one of the jobs of the developmental support tech 4 is to kind of train those lower level techs. So they'll be able to be on the floor more, training more, and again, increasing quality of services.
Thank you. Follow-up, Chair? Go ahead. Thank you. So just a couple more questions, because this is my favorite place. Currently, it looks like there are 40 folks that currently live at Desert Regional Center's Intermediate Care Facility. Has that grown, or are we decreasing the utilization of Intermediate Care Facility that's operated by the state? So there's question 1. Question 2, are there other intermediate care facility providers that are operating throughout even southern Nevada, right? If you just look, because that's where DRC is located. And are we building that level of care from community providers, or is it specifically provided by the state?
Jessica Adams for the record. So for our state ICF, our population has been staying steady around 40 people. We actually have 11 homes on the campus. One of those homes, one rotating home, has been under continual ADA remodel now for, I think, 7 or 8 years. We're on our second to last home that they're working on now. The last home is supposed to be finished sometime in the next biennium, so then we will be back to having 48 beds. I do not believe that there has been a decrease in the amount of people that need an ICF level of service at the state level. I believe once we were able to have that final home on, if we have the staffing, we could probably fill all 48 of those beds. As far as private ICF providers, there are 3 in the state, to my knowledge. 2 who operate in the Las Vegas area, and 1 who operates here in Carson City. Developmental Services does not actually have any oversight over those private ICF providers at all. It's Healthcare Quality and Compliance who licenses them, and then they bill Medicaid directly. So Developmental Services is not involved in building ICF provider capacity at all. We are focused on home and community-based services.
Thank you. Then one last question, Chair. Thank you. So I'm curious to know, and you probably don't have it because you don't oversee, as you just stated, the private intermediate care facility providers. I'm curious to know what the rates are for private providers versus what it costs the state to operate an ICF, right? Like, where are we spending our money to improve the lives of folks in home and community-based services, right? I'm just curious to know that. And so if you could bring that back, that would be great. And then finally, with the Desert Regional Center being located where the Campus for Hope is currently being planned, what are the implications to the existing homes? You just talked about how you've been under renovations for the last 7 or so years. What is going to happen with regard to the Campus of Hope development that is adjacent to where you currently are existing?
Jessica Adams for the record. The Desert Regional Center ICF has no impact from the Campus for Hope. We are part of the capital improvement request for the forensic hospital. That project will be resulting in 2 of our buildings that are currently one totally admin building, one part admin, one part home, being demolished and rebuilt. And then one of our 3rd homes that's currently being used for nursing staff only is being demolished into a home. So we will keep our 48-bed capacity even with that CIP project, but Campus for Hope does not impact us at all.
Can I ask you a question about the need for these additional staffing? I know that, just across the board, state agencies have had problems having vacancies. Obviously, I have concerns that on average, each employee is receiving 10 hours of overtime every week. That seems pretty significant. However, how much of your ability to fill those positions has to do with the fact that there's so much overtime that's boosting those individuals' pay? And do you have concerns that by adding these additional employees to bring down the overtime costs that you might have difficulty filling all of these positions?
Jessica Adams for the record. As I stated, our developmental support technicians have a very low vacancy rate currently. We have not actually had issues filling those jobs. The overtime is coming in because we are serving people that need higher levels of staffing than how the facility was originally designed. Kind of similar to what we're seeing on the home and community-based services side. People are just needing more help.
So have you consistently, or is it just over the most recent biennium that you've been utilizing overtime? Sorry, I'm a little sensitive. There's a lot of overtime money that has come to light across different state agencies. So when I see 10 hours per week per employee, there's some red flags that go off. So have you always utilized these overtime, or just has this been something recently?
Jessica Adams for the record, yes, the ICF has traditionally always had overtime. I believe our overtime usage has actually gone down from what it was last biennium, but we will have to confirm that.
Thank you. I appreciate that. Next, I think we've caught up to the budgets. Yes, I think, I don't know. Do we have any other questions from committee members regarding these 4 items that we've heard? If not, I will direct you to move on to 3266, Home and Community-Based Services.
Dina Schmidt for the record. So budget account 3266 starts on slide 16 for those that are following along. This budget account supports older adults, people with disabilities, and family caregivers by providing home and community-based services to help individuals remain independent and in the community of their choice for as long as possible. This budget includes several programs: our Community Option Program for Elderly, which is a state-funded program, The personal assistance services, also a state-funded program. And then the Medicaid waiver for the frail elderly and physically disabled. Those are two waivers we operate in this program. This budget also has the taxi assistance program, which only operates in Las Vegas. And then we have quality assurance teams throughout all of these programs. So starting on slide 17, we'll get into the frail elderly budget, the frail elderly waiver. So this projections for the frail elderly show a growth of 6% in the upcoming biennium. And I just want to point out, we recently had, our Commission on Aging had data analytics run a report for us. Their question that the commission had was, are home and community-based services working? Do they cost less? And we think, we always say we know that. But in the frail elderly waiver, as an example, the average cost per year for a person in the waiver plus their Medicaid state plan services that they're eligible for, average about $10,719 a year versus a skilled nursing facility, which averages about $32,000 a year. So we know that these services are critical and that they are more cost effective. On slide 18 is our physical disabilities waiver projections. This caseload is projected to grow by 10% over the next biennium. And our community option program for the elderly, on the next slide, you can see the caseload growth is about 6% for this program. And then lastly, the caseload projections for our personal assistance services, you see about a 16% caseload growth. Again, huge caseload growth, demand in services just continues to increase. And then we'll move on to decision units on slide 21. E257 is a continuation of the COPE and PAS rate increases. So last session, this body did approve a rate increase that matched the Medicaid rate increase for these similar services to $25 an hour. So this is just a request to continue that rate increase. Decision Unit E680 is elimination of 5 vacant social work 2 positions that have been vacant for more than 2 years and we've been unable to fill. E901 is a transfer of a position to 3151 just to align with cost allocation. And then you see our M decision units for caseload increases. And those are all the caseload decision units for 3266. We're happy to take any questions.
I'm sorry, could you tell us again? I appreciate you making that distinction on how much these home and community-based programs save our state. You had indicated, what was that amount that you indicated for the costs that it would be if someone was to have to be in a nursing home?
So a person living, so the data we have was for the frail elderly waiver specifically, right?
Yes.
And so just to make it really clear, frail elderly, when you're on the frail elderly waiver, you can live in various settings. You might attend adult day during the day. You could live in an adult group care setting, or you may be living in an assisted living setting, or you may be living in your own home. So the number I gave is an average of all of those different settings. The average cost is $10,719 a year versus a skilled nursing facility where the average cost is $32,000, $226.
I guess this kind of gets me to, I'm like a broken record today. The governor's recommended budget does not include the projected wait lists, again, for these community-based care programs. However, the additional caseload positions would cover the projected caseload plus projected wait lists. Can you kind of discuss what the rationale is for adding those positions to support the wait lists in addition to the caseload that is recommended to be funded? It's interesting to have that administrative staff like there to fund it, but not funding the wait list. Like you're not funding the wait list going forward, but you're funding the positions to administer the wait list. I don't know if I was very clear on that.
Dina Schmidt for the record. Sorry, I had to get some clarification. So one of the things that happens when in the waiver wait list is the intake process. So those positions, regardless of whether we have a wait list or not, we still have to process the intake applications. And so those wait list, the staff for the wait list are the staff that we need to do the processing of the applications, the additional growth, which is very difficult to say that we need people to hire to evaluate people to put them on the wait list.
Okay. Interesting. When you make that decision not to include these wait lists and funding them going forward, what kind of, I mean, we're seeing the budget also presented in silos, but then we also have to like account for them holistically, like throughout the budget. So even in this, you're talking about how to fund this, it is $10,716 on average. And if you are not including those in the budget, what kind of conversations are you having, you know, with other agencies that are now going to see an increased, you know, hit to their caseloads and their budgets if these individuals who could receive services in their home and stay in their home with a least restrictive, more autonomous as they're aging, and we're now putting them in skilled nursing facilities that have an average cost of $32,000, where we already know we have deficiencies there as well. So what kind of conversations do you have with how this budget and not including these wait lists moving forward have an impact on some of these other budgets across the state?
Dina Schmidt for the record. So a couple conversations we've been having, right? So in specific to the frail, elderly, and physically disabled waiver, our staff are the ones that do the case management. The reason we have not been able to enroll more people in the program really is related to our inability to hire social workers. It requires a social worker, and so we've struggled to hire social workers in order to meet the demand for these services. One of the conversations we've been having with the Medicaid division is they have opened up case management to private entities so that we can have additional people providing that service. There is currently a private case management company serving, I can't remember exactly how many people, but in Las Vegas. How many? 413 in the Las Vegas area only. We are working with them, trying to get them to expand to the north. I will say that we have, in the last 6 months, 8 months, we've been starting to see an increase in our ability to hire social workers. It's been slow but steady with the new rate increase or wage increases that was provided to state staff. So we anticipate, we're trying to fill that gap, right, using private case management entities to try to help fill the gap so that we can meet the demand for these services. And we do, I'm sorry, if I may, Dina Schmidt, we do also, just want to make sure everybody's clear, we do, again, in this caseload, we also prioritize and we enroll people who are at risk of institutionalization to avoid that institutionalization. So they are enrolled and served first.
Thank you. I think sometimes we all get siloed into our individual budgets and not realizing that when we cut something like this that has like preventative care that's obviously more cost effective, that we are inevitably opening up more expensive things in other areas. So I appreciate that those conversations are ongoing and I'd encourage those. I think you kind of answered a question that I think the Majority Leader wanted to ask, but I think she may have some follow-up. So I'll go to Majority Leader Canizaro.
Thank you, Madam Chair. I know you were just talking, excuse me. I know you were just talking about the social worker piece of it, and so I think you answered, part of my question had to do with how you have managed the caseloads with existing social worker vacancies, which I think you were sort of getting at, but I guess in follow up to that, are there any other types of positions that can help to manage these caseloads that can work in these capacities, or are you just looking at the social worker aspect of it?
Thank you for the question. Jeff Duncan for the record, through the chair to the senator. We are currently working with Durham to open up another position called a case management specialist. I hope I got that right. I always mess that up. But we're not currently done yet. But we would also like to continue to hire what I affectionately call our unicorns, our social workers, because they do such fabulous work. So we are holding out, hopefully, to not utilize that classification, because our current vacancy rate in Northern Nevada for just my programs on the case management waiver is 34%, and then up in, that's in Southern Nevada, and then in Northern Nevada right now, I'm sitting at, got those mixed up. Northern Nevada is 34%, vacancy 26% in the South.
And what other sorts of efforts, I know you've talked a little bit about being able to fill these vacancies, but what sorts of efforts are you also, anything else you want to add to that in terms of what you're doing to improve the recruitment and retention for those positions?
So it's Jeff Duncan again for the record. So we are partnering with our Adult Protective Services. Our managers are going out, pounding the street to try to drum up and find our unicorns across the state. But the HR from the state is also holding job fairs, and we're trying to do some hiring on the spot to fill these vacancies.
And any idea how that's going to be able to help fill some of those positions and what that might look like in this next biennium, or still too early to tell?
Thank you for the question. Jeff Duncan again. To be determined. Not sure. We're really focused on trying to get our current vacancy rates filled so we can fill these slots.
I appreciate that. I have a couple more questions. Madam Chair, can you talk about the effects on client services and on the wait times that you have for the amendment that we received that changes the caseload positions from start dates of October 25 and December 25 to now start in January of 26, because we got that information in as part of that budget amendment.
Thank you for the question. This is Jeff Duncan. Want to make sure if I break it down two different ways. I think your first question was, just like Jessica, delaying them is not going to impact us because of our current vacancy rate, and it does take us a little bit of time to get individuals hired. Should we get lucky enough and get fully staffed, that'll be a great problem to have, and we would be ready for January. And can you please clarify your second question for me?
Yeah, so the question was what effect that would have on the client services and the wait times that you have with moving those anticipated start dates from October and December into January.
Thank you for the clarification. This is Jeff Duncan again. Right now, it wouldn't have an impact because we still have a vacancy rate, so we don't anticipate even getting to those January positions until we eliminate our vacancies.
So that movement of that date, because it does result in a savings, but you wouldn't be able to fill that as it stands with the dates that were in the original governor's recommended budget because of the vacancies, if I'm understanding your answer correctly.
Thank you for the question, Jeff Duncan. You are correct.
Okay. And then I wanted to ask about some of the wait lists for the community-based care programs, and can you talk to us about what are the factors that are contributing to those wait lists? Because I think we were seeing information here that it's for the personal assistance programs, 58 individuals with an average wait time of 254 days, and community options program for the elderly with a wait list of 13 and average wait time of 218 days.
Thank you for the question, Jeff Duncan again. So I'll have to break down the two programs, the Medicaid programs and then the COPE and PAS, as you mentioned. Our primary factor for the wait list for the waivers is the lack of case managers. Again, our intake teams are processing cases as they come through. Now, for COPE and PAS, it's a completely different story. Back in, let me get my dates right, January of 2024, as mentioned before, the rate for providers was increased, requiring them to pay $16 an hour for the direct care workforce. We, back in February of 24, saw that that had a tremendous impact on the community providers actually maybe hiring people and retaining individuals because our utilization rate shot through the roof. And we knew by February we were already going to be facing a shortfall in state fiscal year 24. So we froze both programs and they remain froze today. So that's the main reason you're seeing these increases in our wait times and the wait list, because we had to freeze the program based on available funding.
Okay, so I just want to make sure I am understanding that correctly. There were a lot more folks who were coming from these community-based providers, but we didn't have the funding to support that? Thank
you for that clarification. This is Jeff Duncan. The main reason that wasn't the providers, it was our individuals that were already on the program had a max number of hours that they could get for the in-home services, a utilization. Once that rate increase went in place, the providers were able to then hire or retain to offer up to the max utilization, which projected out to be a shortfall for that last fiscal year.
Got it. Okay. I think that answers the questions that I have for right now, Madam Chair. So thank you. Thank you.
I think I had a question, but it'll come to me. Next, we'll go to Senator Don Loop.
Thank you very much, Madam Chair. And I know that some of these questions may seem like we're asking the same question, but I think we need to be really clear on what's going on here. So can you discuss the factors contributing to changes to the costs incurred per individual client since the provider rates were increased beginning January of 2024 for personal assistant services and the community options program for the elderly?
So thank you for the question. This is Jeff Duncan, and perhaps I can do a better job of answering the questions too, so it's more clear. I can speak to a couple things on the for COPE and PAS. Let me make sure I find my notes because there's a lot of data that we put together. So I'll break it down in a couple different time periods. So if we go back to July of 2023 through December, the average cost per individual for COPE was $612. And then for PAS, that was just a little over $1,100. Then if you fast forward to when the rate increase went in place, January of 2024 through June of 2024, the cost per person for COPE went up to almost $1,300 and $2,100 for PAS. Currently, in the current fiscal year, we're projecting about $1,300 per person for COPE and almost $2,400 for PAS. And that's mainly, again, because of the utilization that was the hours already approved. The providers are now able to provide that.
Follow up, Madam Chair. Yes, go ahead. So, when you say those, when you gave us those figures, like the first one from July to December 2023 for COPE was 612, is that, are the current average costs per individual per month for these programs?
This is Jeff Duncan, correct, per individual.
Okay, so right now for COPE, well, it went up after June of 2024, went from the 1,300, and what was the figure you gave us?
So it's Jeff Duncan again, from January 24 through June, it was $1,280 for COPE and $2,120 for PAS.
Okay, thank you. And then I've got a couple other questions. The executive budget reflects the estimated service costs per individual as $1,947 for personal assistant services and $1,153 for the community options program for the elderly caseloads. So can you clarify how those costs were decided and whether these amounts are anticipated to be sufficient to maintain those services for the existing clients and cover the projected caseload?
Thank you for the question. This is Jeff Duncan. I'll try to handle the first part. What we know right now, based on our current estimates, that we're going to be slightly above those projections. Again, going back to our current estimates for 25 is $1,300 for COPE and 23, almost $2,400 for PAS. And again, what we would need to do in the new fiscal year is that we would have to, again, look at our cost per person and potentially adjust our overall caseload plus the supplemental you see in our budget. So right now, we're not sure what the projected caseload will look like for the new fiscal year. We're just going off the current averages.
And one last question, Madam Chair. So how does the agency ensure that these services are appropriately utilized and billed?
So it's Jeff Duncan for the record. Every individual on the program has a case manager that helps monitor that case, and then we have our provider billing under our quality assurance unit. So dedicated individuals to watch both of that.
So the quality insurance group sort of oversees that billing from those personal assistants?
This Jeff Duncan for the providers, correct.
Okay. All right. I think that's it, Madam Chair. Thank you very much.
Thank you. Do we have any other questions from committee members here? No, look at that. I know. I'm feeling very good about the timing, not so much about some of the things we heard today, but I appreciate all the work that you put in here and your candor in moving forward. And I know we will continue to have some more discussions about what we need to make sure that we don't further get into a hole with some of our most vulnerable individuals in our state. And with that, if I don't see any other questions, I will close that budget hearing. And thank you for your time. And we'll move into our last agenda item, which is public comment. And I will ask anyone either in Las Vegas or in Carson City to come to the table to testify in public comment. I don't see anyone coming to the table. Oh, wait, maybe, I don't know. Yes, I think so. Wonderful. I would remind you to please state your name clearly for the record. And we will start here in Carson City. Go ahead and begin when you're ready.
Hi, this is Jessica Padron for the record from AARP Nevada, speaking on budget 3266. Just want to share our support for the work that's being done by Dina Schmidt and her team, and reinforce the importance of ADSD getting the budget funding they need to support with the home and community-based waiver, specifically the importance that this waiver provides, critical not just for seniors, but caregivers, ensuring a better quality of life, respite support, and positive health outcomes, not just for those who get the services, but for their caregivers. So that's all. Thank you very much.
Thank you. I don't see anyone else here in Carson City, but I do see some people in Las Vegas. Go ahead and begin when you're ready. Again, please state your name for the record before you speak.
Good morning. My name is Denise Robinson. I am the guardian and mother of Ryan Robinson, who resides at the ICF here in Las Vegas at DRC. I have 4 points that I wanted to take up with all of you today during this meeting. My first comment would be about staffing. I am very involved in my son's life. I visit him at least once a week at the regional center. I'm an anomaly because I don't ever see any other parents or guardians at this place. So I have a very deep love for all of these people that reside there in my heart. But some of the things that I want to talk about really quickly are the staff issues. There's a big turnover for staff. Those are the staff that actually work with the individuals themselves. Morale is another issue. Training is another issue, as well as staff simply discussing the well-being of their children or their people with guardians and or parents. There's a lack of transparency that goes along with all of this. I think that morale is a problem due to getting schedules not as they would prefer. I know that there were staff members who wanted 2 days off in a row and they weren't given that, so they moved out of that building to another building. There has been training that has not been provided as frequently as needed to be. This is a hard job for these people, a very hard job. They have to learn how to deal with children, and they're all children to me, so please forgive me. But they have to deal with these people that have they're cognitively disabled, they're mentally disabled, they have lack of communication skills. And this isn't just easy for somebody to step in and take care of. So they need training more than once a year, especially if they are in situations where a resident may become agitated and aggressive. The second thing I want to talk about is transparency, communication. As a guardian, I have to beg for things like incident reports, documentation, data, asking questions about how my son is doing. What happened? I don't know. How did this happen? I don't know. Where'd Ryan get those bruises? I don't know. I'm tired of I don't knows, and I want answers. I want transparency. I want documentation. I want it clear. That's not too much to ask for as somebody who is a tax-paying citizen who supports this. Not to mention the fact that my son pays these people his Social Security to take care of him. He and all of the residents that reside at the ICF are the patrons. They're the ones who are paying you. You're not doing them a favor by taking care of them. And I want that very clear. I want you to remember that. And as far as the JDT goes, as some of you may remember, I testified a couple of weeks ago about my son having a problem in the summertime with abuse, lack of documentation, no support from APS and ADSD. There has to be better supervision of JDTs and private people, providers, as well as the ICF. There needs to be people that are not working for the ADS, but some neutral company that can come in and make sure that they are following the rules for the state of Nevada and for each individual. And it's a huge deal because there is safety problems, there's abuse problems, and there is extremely bad documentation. And I'd love to have the opportunity to show you what kind of documentation the JDTs and even DRC is utilizing. And I don't know how they get any answers for you. My third thing is, as far as the supervisors for DRC and in for each building, that is a vitally important thing. And I'll tell you why. A couple weeks ago, or about a year ago now, my husband and I made a visit to my son. It was 9:30, 10 o'clock on a Sunday morning, and we came in. It was pretty quiet, and entered my son's room, which was with the closed door, and we found a contracted person laying in his recliner with a blanket over her, sleeping. There was no supervisor in the building at the time. I later learned that there was a supervisor on campus, but I had no opportunity to talk to anyone and had to write emails to people and take care of it the next day. Completely inappropriate. If we're paying people to sleep, we got really big problems. Another reason why we need people there to make sure that these people are doing their jobs. So I absolutely 100% support having a supervisor in the building at all times, frankly, not just one shift a day, but 3 shifts. Every shift has to have somebody supervising, making sure these people are doing their jobs. I'm currently waiting to find out about a situation that happened on the graveyard shift where somebody put hands on my son. Haven't gotten that information yet either. And finally, as far as the wait times go and the lack of services that we are being able to provide as a state to our most vulnerable people in our community, and I absolutely believe the state is only as good as its weakest are. And it's very important that we pay attention to this, but perhaps we can start looking at the prioritizing of our taxpayer dollars. Instead of spending $360 million for a stadium on the Strip, maybe we should actually put it into the people that actually need it. Because every single one of you will be in a position where you will be disabled and you will need help and your family will not be able to take care of you. And it just so happens that it happens to all of us. And I hope that you will take this into consideration, that you will take it to heart, and that you will understand that these problems will affect you personally sooner or later. And I hope that you will be able to make these changes. Thank you.
Thank you. And if we can go to the next person that is there, go ahead and begin when you're ready.
Good morning, Madam Chairs, members of the subcommittee. Stephen Cohen, for the record. Stephen with a V. Cohen, as in the now former Assemblywoman. First, I want to thank you, Madam Chair, for indulging the previous speaker. As many of you know, this is a difficult issue, and I know that hopefully that time won't take away from Mr. Leiser's video that he still owes us from IFC, but that's offline. But just want to put on the record that the division and director's office have my commitment to working offline to fix this problem. Thank you. I yield.
Thank you. Sorry, I needed to pan out. Do we have anyone else to testify in Las Vegas? I don't see anyone there. AVH, if we can go to the phone lines to see if there's anyone to testify in public comment.
Thank you, Chair. If you would like to offer public comment today, please press *9 now to take your place in the queue.
Hi there, my name is Benjamin Chalmers for the record. That's BenjaminChallinor. I am the Director of Public Policy for the Alzheimer's Association. Here to talk about budget account 3278 from ADSD. I know it was not talked about today, but I just want to make sure I get something on the record as well. In particular, this budget account is the Planning, Advocacy, and Community Grants. Within it is the Dementia Respite Program. And about 2/3 of the money that comes in for that comes from the tobacco settlement, and the remaining comes from the state general funds. Currently, it is capped at $1,000 per person per year, and we're looking to increase that to $2,000 per person per year. ADSD has mentioned that they would be able to do that if they're able to receive that additional funds from the state general fund. So I know that the budget account has not had a hearing, but we would once it does, if it does, or as the budget conversations are happening, we'd love to see that increase from the state general fund. I know we'll have a better idea what that budget will look like after May 1st and well after that. So thank you all for your time, and thank you.
Thank you. If we can go to the next caller.
Caller with the last 3 digits, 466. Please press *6 to unmute yourself, and you may begin.
Hello, members of the committee. For the record, my name is Kelly Rose Pion Capone, Pion-Capone. Socrates once said, "You don't know what you don't know." And reflecting on 4 years ago when we received the phone call, our lives took a significant turn. We became full-time caregivers to my mother, Sharon, who had been diagnosed with Alzheimer's. I feel fortunate that we could care for her at home, especially with the support of my husband, who insisted she live with us instead of going into a care facility. We've been surrounded by an amazing network of people who have offered love and support throughout this journey. As my mother's Alzheimer's progressed, the demands of caregiving became more challenging. I found myself learning more about Medicare, Alzheimer's care, neurology, speech pathology, physical therapy, UTIs, CTs, MRIs, and in-home health care. I developed a deep respect for the individuals and professionals in these fields. Despite gaining all of this knowledge, I still found myself questioning whether I was doing enough for my mom and if I was providing the best possible care. Over time, the emotional and physical toll of caregiving became apparent. I realized I needed help. And that's when the team at Manila Adult Daycare in Las Vegas introduced us to the respite voucher program. Excuse me. The adult daycare had been an enormous help in giving me time to rest and recharge, but the respite vouchers made it possible to access this care without the financial strain. The vouchers helped cover the cost of care at Manila Adult Daycare, allowing me to step away from caregiving and focusing on the needs of myself. Manila Adult Daycare provided a safe and nurturing environment for my mom during the day when she received care and had the opportunity to engage in activities. Knowing she was in good hands made a big difference, and it allowed me to run errands, rest, and just take a break. The respite vouchers were essential in making sure I could take these breaks without worrying about the financial impact. It was a relief to have the support, and it helped me stay mentally and emotionally healthy so I could continue to care for my mom. The breaks I received gave me the space to recharge and reconnect with my own needs. It wasn't about taking away from caregiving. It was about ensuring my mom was in a caring environment while I could take care of myself. These moments of respite allowed me to return in my caregiving responsibilities with more energy and focus, helping me to provide the best care for my mom. Eventually, as my mom's care needs increased, we made the difficult decision to move her to a facility that could offer the 24/7 care she needed. It wasn't an easy choice, but having access to respite care helped me gain clarity and confidence in making the decision. I knew that with the support that I'd received from Manila Adult Daycare and the Alzheimer's Association, I was doing what was best for her. In all actuality, it's meeting my mom where she's at and not about me. Looking back, I've learned that taking care of myself is just as important as taking care of my mom. The respite care gave me for the time to recharge and to be the best caregiver I could be. This experience has shown me that caregiving is a shared journey. We can't do it all on our own, and seeking support is an important part of the process. The respite vouchers from the Alzheimer's Association were a lifeline for us, allowing both my mom and me to benefit from care, rest, and peace of mind. I actually never thought that I would be saying anything like this about my mother. Anyways, thank you for your time, and I will answer any questions the committee may have.
Thank you for sharing your family's story. If we can go to the next caller, please.
Good morning, Madam Chair and members of the committee. My name is Marlene Lockhart, and I'm representing SEIU 1107. We are very grateful to the legislature for the support and attention that you all have given to home health care workers. And by the testimony and information you've heard today, you can see, as you well know, the tremendous needs that exist in our state. And the fact that the waiting list is not funded going forward is very concerning. You were so helpful in increasing the compensation for healthcare workers in the past, and we are so excited to report that it's actually working, that the retention and higher rate has increased at a time when we have the absolute need and there exists a shortage of healthcare workers, home healthcare workers. So, again, thank you for your support and for your efforts now to diminish the wait list and find appropriate funding with the ever-increasing senior population in Nevada. Thank you very much.
We can go to the next caller for public comment.
The public lines are open and working, but there are no further callers to offer public comment at this time.
Thank you. And with that, we will close public comment. I thank everyone. I thank our people that came in to testify in public comment. I think it's always important that we see, especially in these budget hearings, where we don't often get to receive testimony about how these services impact our community and our families within our community. So thank you to all of those that called in and came down to the building today. And with that, meeting is adjourned.